Welcome to ATCM, the Emergency Medicine Channel. A 70-year-old male presented to outside hospital with one episode of syncope and was found to have bradycardia with hypotension. He was
Can you
managed.
define syncope?
Syncope, sudden loss of consciousness. With sudden loss of consciousness, it may be associated with
Define syncope.
Loss of consciousness without any
post-ictal confusion.
Define syncope.
Sudden loss of consciousness without any loss of with loss.
Transient loss of consciousness with the
Transient loss of consciousness due to reduced supply to the brain, and patient regains consciousness immediately after falling down. That is syncope. Because there are a lot of causes for loss of consciousness. You can have hypoglycemia. They will not regain their consciousness after falling down. There can be seizure. They will not regain their consciousness after falling down. So by definition, because of reduced perfusion to brain, patient loses his consciousness. He falls down. Immediately after falling down, cerebral perfusion maintains and he regains consciousness without any post-LOC confusion. That is syncope. Okay.
And was one episode of syncope and was after that he regained consciousness, then was taken to outside hospital. There a patient was having bradycardia.
So you have to tell regain consciousness, but there is no confusion. Then your seizure is completely ruled out.
And was found to have bradycardia with hypotension. From there, patient was referred to our ER. On initial 10-second assessment, airway was patent. Patient was
Can you tell the reasons for bradycardia with hypotension? According to ACLS, there are few reasons for bradycardia with hypotension. If you know that, it's easy to manage.
So one is inferior wall MI. We have bradycardia with hypotension.
5H and 5T, that is easy to remember.
Okay.
You should know that.
Bradycardia,
there are few causes that will be mostly associated with hypertension. Mostly, not in all. Like hyperkalemia, it may not be associated with
hypotension.
But what are the reasons for bradycardia? Significant bradycardia.
So one is any inferior wall MI can cause bradycardia. Hyperkalemia can cause bradycardia. Any drug-induced toxic digital
You are mixing everything together. Cardiac causes, non-cardiac causes. Cardiac causes, non-cardiac causes, brain causes, lung causes, like that if you divide it will be easy. What are the cardiac causes at least?
Cardiac causes will be heart blocks.
Heart blocks. Most important is bradycardia is due to heart block.
Then due to any
inferior wall MI, you already told. Inferior wall MI and heart blocks. Most important two causes from the heart. From the lungs?
Hypoxia.
Hypoxia due to what? What causes significant bradycardia, hypotension in lung condition? Pneumothorax? Tension pneumothorax? Tension pneumothorax is one of the cause. These are the correctable cause. Initially there can be tachycardia, but at the end of that process, patient will have severe bradycardia and hypotension. Okay, then toxins. What toxin?
So any beta blocker toxicity.
Okay, beta blocker, calcium channel, digoxin, OP poisoning. Okay.
So
brain what
bleed,
is it?
Any IC bleed,
Cushing's reflex.
If it develops.
Okay. So you should know basic causes, like what we can do manage in emergency room. We should know. Okay. Because all these causes, what we are seeing may not respond to your atropine. That's why. Okay. If it is a complete heart block, it will not respond to your atropine. Okay. If it is hyperkalemia with bradycardia, it will not respond to your atropine. Okay.
So on initial 10-second assessment, patient airway was patent. He was speaking in full sentences. Breathing, respiratory rate was 18 per minute with saturation 99% room air.
Can you get bradycardia while intubating the patient?
Yes, sir.
Yes. So you have to be very careful this type of patients. Suddenly they can go to cardiac arrest.
Circulation was BP was 130 by 80. Patient was already started on adrenaline infusion from outside. So this BP was on adrenaline infusion. Heart rate was 103 per
What are the
minute.
infusions you can start when the patient is having hypotension?
Sir,
Any patient
initial
come with
fluid,
hypotension, what is the first response?
fluids.
Fluid.
First fluid.
Second response?
Noradrenaline.
Noradrenaline. Third response? Vasopressors like vasopressin or dopamine.
Dopamine.
Okay. Instead, you can directly go to adrenaline. There is no issue in that. Like instead of noradrenaline, you can go to adrenaline in some situations. Okay. But this patient is on adrenaline. Okay. What is the common? It is not common. What is the major side effect of adrenaline infusion?
Tachycardia, hypertension.
Tachycardia and what is tachycardia is an effect. Patient who had received adrenaline infusion or adrenaline shot, what major side effect they can develop in heart?
Arrhythmias.
That is tachycardia and tachyarrhythmia. What development can produce in the heart? Huh? It produces some cardiomyopathy. What is that? Takotsubo?
Takotsubo's
Cardiomyopathy. That is a problem in when you are giving high dose of adrenaline. That's why adrenaline, there is an infusion protocol. You have to start noradrenaline and wait for some time. Adrenaline directly can be given in conditions like anaphylactic shock. That is the only shock where adrenaline is a first line drug. But some doctors prefer adrenaline over noradrenaline. That is acceptable. Okay, but that can sometimes produce problems, serious issues like Takotsubo cardiomyopathy, dilated ventricle.
GCS disability wise, GCS was full and pupils were bilaterally equally reactive. Exposure, patient was afebrile and GRBS was 182 milligram per deciliter. So initially, sir, we took a ECG for the patient and a VBG for the patient. VBG was showing a pH of 7.285, PCO2 35.6.
7.285 acidosis. Okay.
Bicarb was 16.4, lactate was 11.
Okay.
Lactate
So what do you
acidosis.
think a patient's lactate is elevated? What are the possibilities? He had a bradycardia, he had loss of consciousness, lactate is elevated. What are the possibilities?
Shock per patient.
One is shock, patient is in shock, that's why lactate is elevated. Other possibilities? Only one possibility means we cannot survive. We have to- Seizure. Next possibility is always seizure. Seizure is one condition where lactate can be highly elevated. So keep that in mind. We have not witnessed the problem. We are seeing somebody's description and making a diagnosis. But lactate is elevated. Suppose the patient is not having hypertension, lactate is elevated, loss of consciousness, seizure is the first DD. Okay.
So we also took an ECG. ECG was showing a heart rate of 101 and it was showing ST elevations in lead 2, 3 AVF with ST depressions in 1 AVF, V5 and V6.
So you want to have a previous ECG, like ECG taken that hospital, or directly you believe this ECG?
So we believe this ECG.
There is a problem because we don't know what is a ECG, previous ECG. Patient is on adrenaline infusion. Adrenaline is one drug which can produce ECG ST elevation because of tachycardia. Patient is already having some coronary artery disease. It can be aggravated. That's why we need a previous ECG to compare. That ECG might have taken in that hospital. We have to always compare. Suppose this ST elevation is a new change after adrenaline infusion, we have to be very careful in interpreting that ECG. But already there is ST elevation from that hospital after that adrenaline is started because of hypertension. That's okay, acceptable.
So coming to sample history, 70-year-old man presented to the outside hospital with one episode of syncope, which occurred while he was climbing upstairs. Then he fell down, sat on the stair, and regained consciousness. After that, he was taken to outside hospital. There, this episode was also associated with sweating. In outside hospital, they initially took an ECG. ECG showed a heart rate of 45 with junctional rhythm. With BP
junctional rhythm means what? What do you mean by junctional rhythm?
Sir, P waves will be absent, and sir, there will be narrow QRS and P.
AV node. What is the intrinsic rate of AV
40
node?
to 60.
42?
60.
So normally SA node is 70 and above.
70.
AV node is 60, somewhere around 60 or below. bundle of his and
Less
per
than
kg
40.
fibers less
Less
than
than
40. Okay. And the QRS will be wider.
Narrow.
Here it will be narrow. In junction it will be narrow. If it is going to per kg fibers, it will become wide. Okay.
And so his BP was recorded to be 65 by 40. So at GRBS they had checked, it was 200. At that moment they had given injection atropine 0.6 mg IV
Has he
stat.
had any chest pain?
No, patient never complained
Why
of
he
any
is not
chest
having
pain.
chest pain? What is the
Patient
reason?
was diabetic.
Diabetic. What is the reason for absent chest pain?
Uh,
Diabetic patient typically present like this. They are present with dyspnea on exertion or bradycardia, heart blocks. That will be the classical finding of diabetic with MI. What is the reason for that? What is the reason?
Neuropathy.
Which neuropathy? What
Autonomic
autonomic
dysfunction.
neuropathy? So sign of autonomic dysfunction. Pain of cardia will not be perceived by the patient. Okay.
Patient was also given 1 pint of NS bolus, and after that patient was started on adrenaline infusion from there.
Okay.
And patient was shifted to our ER.
Okay.
Patient
Why
is not
patient is given NS in this case? What is the reason for fluids in myocardial infarction in this patient?
Sir, usually if patient is having myocardial infarction, if patient is having right ventricular failure, then the choice of treatment is fluids first.
Fluids.
Sir.
Left ventricular failure?
Sir, we have to restrict
We have
fluids
to
like
restrict. So
inotropes.
that is the difference between RV failure and LV failure. LV failure, you restrict fluid, you start noradrenaline first line, or here adrenaline is started. In RV failure, it is the choice is always fluid, then give adrenaline, noradrenaline, or dopamine, whatever it is.
And so, he is not allergic to any known substance. He is a known diabetic.
Which substance you have to check? He told allergic. Which substance can produce heart attack? Substance abuse. Which substance abuse can produce acute coronary syndrome? Cocaine can produce. Young patients coming with ST elevation, coronary artery disease, high BP, you have to always suspect cocaine.
In our ER, on examination, patient was conscious oriented. He was not having any complaints of any chest pain, palpitations, any sweating, any radiation of pain to shoulder or to back. At that moment, we started the patient. Our BP at that time recorded was 130 by 80. We started to taper the adrenaline, and we started the patient on IV fluids.
Okay.
At the same time, loading dose was given to the patient, and cardiology
How
was
much
informed.
IV fluid you give normally when you have a hypertension with inferior wall MI? You have to give one bolus of one pint, that is 500 ml. Just give 500 ml. See the patient response. If the patient is not improving, then don't give additional fluid. If the patient improves, then you start the noradrenaline and continue. Like little more fluid may be required. 500 will be enough. Okay.
We also informed cardiology. We gave him a loading dose of aspirin 325 milligram, Piostat, then ticagrelor 180 milligram, and atorvastatin 80 milligram.
Okay.
And then all pre-cath investigations were sent. Echo was showing basal inferior and basal inferoseptal mild hypokinesia with overall fair LV systolic function.
Okay.
And then so he was immediately shifted to cath lab.
Okay.
From there, angiogram was done. Right proximal RCA occlusion was there.
Okay.
They stented the patient and then shifted to CCU.
Should we have not taken right oriented leads in ER. We should have done it. Okay. So when the patient is having hypotension, bradycardia, heart blocks, why patient develops heart blocks in inferior wall MI?
So there, either it could be due to AV node dysfunction, or it could be due to vagal tone.
What is the reason for AV node dysfunction in inferior wall MI?
If RC supplies the
Okay, so the same blood supply is there for your SA node and in AV node. Okay, inferior wall also supplied by same area. Some patients can have diaphragmatic problem also. Some patients can have cuffs. Okay, all these things are due to same supply. Okay.
I think that CKMB and we had sent cardiac enzyme, but since already ECG changes were there, patient was immediately taken up. Later, CKMB came out to be 83.5.
Okay. So which is most specific, CKMB, troponin T or I or ECG? Which is more specific?
ECG.
ECG. Sure.
If ECG changes are there,
Huh?
top T.
Suppose you have a patient who is having a previous myocardial infarction. STI segment is elevated for a long time because of ventricular aneurysm. He is coming to your ER. Chest pain will be there naturally.
Then CKMB, reinfarction.
Which is more specific in emergency room?
Top T.
Trop T, trop I is more specific. Okay. But in reinfarction,
CKMB.
CKMB is better than trop T. What is the reason for that?
Because sir, top T remains elevated for around 14 days after the initial attack.
So it can still elevate even after the acute problem is over. It can be still elevated. But CKMB elevates and drops down within 48 hours, completely normal. Then if the patient develops one more episode of MI, CKMB only we can depend on. Okay, so ECG or CKMB, depending on the scenarios, it may not be useful, but TROP-I will be more specific. Only thing is, if ECG changes, like you will be taking first ECG. After half an hour, if the ECG changes are increasing, then that is a good, it's a strong sign of acute MI. Okay, that's all. Some patients with MI and after some time also they can have ST elevation persisting. Up to 6 weeks they can have. That is because of ventricular aneurysm. Okay, so in that condition, ECG alone will not be sufficient. Okay, and some patients ST elevation can be there in like Brugada syndrome. We can get ST elevation in anti-relates. How do you differentiate that from acute MI? How do you differentiate? One is progression. Second one is reciprocal changes. Here you are having reciprocal changes. So you have to always look for all the parameters. You look for ECG changes, increasing in ECG changes, trop-I, trop-T, and reciprocal changes. So everything together you can tell the patient is having myocardial infarction. Some patients you can get deeply inverted T waves. Cardiomyopathy, many patients you are seeing. But if the trop-I is elevated, then it becomes non-ST segment elevation MI. So everything all together you are making a diagnosis, not a single point. But among all these things, most important is trop-I, trop-T. Trop-I, trop-T, any difference? There is no major difference. Here we do trop-T. That's all. Anything else? Okay, thank you.